Hi, this is Dr. Bernstein with our February 2020 teleseminar. Before we get into our questions, we have a few special subjects I'd like to cover. One has to do with the flu, which is now pretty widespread in the USA and probably around the world. Those of you who have read my books know that I've been recommending Sambucus, an extract of the black elderberry tree, for prevention of influenza infections. Doesn't work 100%, but it works. In one study, about 70% of the users did not get the flu. I recommend that when people are exposed to the flu, that they start a treatment with Sambucus. It comes in lozenges and a liquid. For the least carbohydrate for diabetics, I recommend the lozenges. You suck the lozenges. The dosing is 2 lozenges every 6 hours within 3 hours of initial exposure or infection. I extend that and say, if you think you might be exposed, you start taking it. If you're going to a theater or going on an airplane, even if it's not flu season, colds spread in the airplanes very rapidly, and it's a good idea to take 2 lozenges every 6 hours if you're flying. I see mistakes in the use of the Sambucus very frequently. Just today, I had a phone call from a lady patient whose blood sugars have gone up. Her children came home from school with the sniffles, as she called it, and she's been taking 1 Sambucus twice a day all winter in anticipation of possible exposure. But here the kids came home sick. They eventually developed the flu, and she had real exposure. For that, you need 2 tablets, 2 lozenges every 6 hours. She didn't up her dose, and she now has a congested throat and a fever. So it happened pretty rapidly. So the game plan is, if you're exposed, you take the full dose. If you're thinking of being exposed, like going to a group meeting in the wintertime, take the full dose. If you're just being cautious in the wintertime, to take 1 or 2 a day is okay, but don't avoid taking the full dose when you're exposed. Okay, the next little subject is a study of obese postmenopausal women who are put on diets to lose weight, reduce the chance of diabetes, etc. And what was found, and they were on 2 different diets that were studied. One was an extreme diet of only 800 calories a day, and the other was a more moderate diet. The people on both diets lost weight. Those on the extreme diet lost more weight, but they also had very significant bone loss. Eventually, when they went back to their old diets, they regained the weight, but the women on the extreme diet did not regain the bone. And that reminds me of what I've been warning about people who endure fasting to treat their diabetes, where there are all kinds of fasting regimens, like every other day, every other week, etc., etc. And these people lose fat and muscle while they're fasting, and later on, when they restore their usual meals, they gain back the fat but not the muscle. So now we see that even can extend to bone in postmenopausal women. We have another study from the December issue of Diabetes Care, which is published by the American Diabetes Association, and it reiterates something that I've been saying for years. In this particular study, type 1 young adults were studied who would appear in clinic, and what they found was, and they would check a blood sugar on arrival at the clinic, and the greater the variation in blood sugar from one visit to the next, the more damage to the hippocampus of the brain was found. So highly variable blood sugars, which, by the way, are associated usually with high hemoglobin A1Cs. That was a study that, there were two studies that I presented at prior teleseminars. We know that people with higher hemoglobin A1Cs tend to have higher blood sugar variability. Now, this study of high blood sugar variability leads to damage to a particular site in the brain called the hippocampus, which is responsible for the conversion of short-term memory to long-term memory, also for navigation. Where are you located geographically? People who get lost driving their car or riding their bike may have hippocampal damage. And there are certainly additional functions of the hippocampus, but this is just reiterating the effect of blood sugar on the brain. Now, even though this was published in the Journal of the American Diabetes Association, the American Diabetes Association still recommends high blood sugars for type 1 diabetics, especially young ones. It's an endless battle. Now we're going to get down to our questions. Before we start the questions, I want to remind you that the answers I give are generic answers. They are meant to educate the large body of listeners, not necessarily solve the questioner's problems, because I haven't gotten a full medical history, don't know all the medications the person is taking, haven't examined him or her, etc. So it's very hard to give an answer that works. But it has a good likelihood if you look at the general diabetic population. I am 49 years old and have hemochromatosis. Hemochromatosis is an iron storage disease where the tissues of your body, including the liver and the brain, retain too much iron. These people have trouble unloading iron. And the iron in the pancreas and the liver can cause type 1 diabetes, and it can even cause psychosis, and the darn stores in the brain can cause psychosis. So I have hemochromatosis and type 1 diabetes. My ferritin level, which is a measure of body iron load, is at 122, but it has been as high as 240. My question is, what is your opinion of an ideal target ferritin level for someone with type 1 diabetes? Well, my recollection is that people with hemochromatosis should be donating blood until they get their ferritin levels down to normal. But this is what I was taught in medical school, and I don't know if it's up to date. So this person should be seeing a hematologist, and the hematologist should decide what his ferritin level should be and what the treatment should be. I assume that the treatment is still removing blood periodically, but the hematologist decides how much and how often, and likewise what the ferritin level should be. I'm a skinny diabetic type 2, 120 pounds. My dawn readings are sometimes around 130 to 135 milligrams per deciliter. Would it make sense for me to take Actos 15 milligrams before bed to see if it lowered my morning readings and maybe help me gain some weight? Well, the weight gain that Actos has been criticized for is principally due to fluid retention. Doesn't cause fluid retention in everybody, but it does for many people, and that's the kind of weight gain that you might be imposing. Now, what treatments are there for type 2 diabetics who want to gain weight? Well, the most effective is insulin, but for some type 2s, the insulin might have to be diluted. So it's a very good idea to read my book, Diabetes Solution, to read about the use and dosing of insulin. Another way to favorably affect the morning blood sugars, dawn phenomenon, would be to eat less carbohydrate at dinner. But of course, you might lose weight if you do that. Another way of treating the morning blood sugars is to take slow-release metformin at bedtime. The Actos or Avandia will help lower the morning blood sugars and prevent increases in the early morning. Avandia, in my experience, has less effect on fluid retention than Actos, but it can also cause fluid retention. So probably you should read my book, Diabetes Solution. I'm a type 2 diabetic. I discovered your system in your book, so I started the low-carb diet you suggest and the anaerobic weight exercise. My glucose curve became immediately good, stabilizing to 120 to 85 during the day and an A1C of 5.9 after 4 months. But I have never been able to bring Toujeo insulin lower than 26 units in the morning. Toujeo insulin is very concentrated glargine or lantus insulin, 300 units per cc. So this person probably is very obese and insulin resistant if taking such a high dose of Toujeo insulin. Now, there could be other reasons. The person could have a chronic infection. He also takes metformin and Januvia, but his belly fat is still there, so I need something else. Do you think intermittent fasting might be the solution to get rid of the insulin? Well, the large dose of insulin is probably due to severe insulin resistance caused by the belly fat. So I would suggest that he lower the dietary carbohydrate even more, and see what happens. He could also lower his insulin resistance by increasing the metformin. He could consider Avandia, which lowers insulin resistance, and he might also be taking small doses of insulin before meals instead of the large dose of Trigeo, which may be forcing him to eat. Remember, one of the old standard ADA approaches to treating type 1 diabetes is to give large doses of what they call basal insulin, forcing the patient to eat all day long. That was to save them insulin shots so that they wouldn't have to take small doses of fast-acting insulin before meals. So there are several things that can be done, but the key to all this is losing belly fat. Recently diagnosed type 1 daughter, age 14. Do you recommend the Dexcom monitor? My daughter is so freaked out by the finger pricks that it would be so nice to have at least some of the checks done without pricking. We are trying some of your techniques from the book for painless finger pricking with mixed results. Well, first of all, contrary to the advertising, the continuous glucose monitors do not lower the need or reduce the need for finger sticks. The continuous glucose monitors are not measuring blood sugar, they're measuring glucose in interstitial fluid, which can run from 20 minutes, well, let's say 10 minutes to half an hour, 10 minutes to 40 minutes behind the actual blood sugar. They also can frequently be way out of line with the true blood sugar. The value to a continuous glucose monitor is if it gives audible emergency warnings to let you know when you have a very low blood sugar, and then you check it, because it might not be very low. It might be even slightly elevated, but a lot of the warnings are correct, and you're doing this for safety. So what can you do to eliminate painful finger sticks? First of all, you might want to try the Gentel, Gentel, butterfly lancets, which are finer point than all the other lancets that I know of. Although they've been treated to be long-lasting, that is, you can reuse them, they nevertheless can get dull, so you have to replace them frequently. Another trick is to don't press hard with your lancing device. I have a lancing device, and if I barely touch it to my finger, I'll get a less deep and less painful stick than if I push real hard. So be gentle with the lancing device. Those two tricks can make all the difference in the world between a painful finger stick and one that isn't painful. You have to experiment, and there are many sites around the finger that you can use. I take nighttime Lantus, which is extremely painful. The endocrinologist prescribed 22 units. It gives me so much pain, What do you recommend I do? Well, Lantus insulin must be kept at a low pH. That is, it is acidic. It has a pH of 4, whereas the normal pH of a body is about 7.3. So it's quite acidic. Why does it have to be acidic? Because when it is in an acid state, it is not readily soluble in the fat in the body and dissolves slowly. The body pH changes that acidity, makes it less acid, so it becomes more soluble over time. So this is how the time release effect is generated, by taking an acid solution and gradually making it neutral, just by exposure to the body. And acid can be painful. They actually add hydrochloric acid to the neutral solution when they make it in order to make it acid. And a number of people find that it burns. So the game plan should be to switch from Lantus to another insulin. Probably the best insulin to switch to would be Tresiba, which is longer acting. There's also Levemir. Another problem with Lantus insulin, which I've pointed out, is that it has 165 times the affinity for IGF-1 receptors than human insulin does. And the IGF-1 receptors are prevalent in cancer tissue, and you can make cancer cells replicate by stimulating IGF-1 receptors. So Lantus has an increased cancer risk. Now, the dose, 22 units, is a large dose, and it could be that you may not need it all to be given in one shot at nighttime. Most of the shots that I give of long-acting insulin, or that I prescribe, are twice daily, smaller doses. I take 3 units of Tresiba at about 4 a.m. and at bedtime. And of course the dose does depend upon how much insulin you may be making yourself, and also upon your body weight. I'm now experiencing dizziness with low or high blood sugars, and even when I am dropping from high 180 to low 60, I have had so even while dropping, I've had type 1 diabetes for 51 years. Please explain. So this person is a survivor. He or she has survived 51 years with type 1 diabetes, which is pretty rare. I've survived 74 so far. Now, one thing, first of all, there are many people who experience the symptoms of a low blood sugar when they're dropping from high to low. Likewise, if someone is used to a high blood sugar and they now have a low blood sugar, they may be very uncomfortable and have symptoms of hypoglycemia. So one problem is to keep the blood sugars normal, not let them get high, and not become used to the high blood sugars. Another possibility, since you speak of dizziness, and usually when people speak of dizziness, they're really speaking of what's called near syncope, where they feel like they're going to pass out. And that frequently can be due to low blood pressure. So if this person has low blood pressure, they may be more likely to experience their symptoms. Furthermore, since he or she is having blood sugars as high as 180, they may be dehydrated. When your blood sugar is that high, you pee away glucose, and you can easily become dehydrated. And dehydration can lead to low blood pressure and what's called near syncope. So there are many options as to what may be going on. And of course, real, true low blood sugars can cause discomfort and make you feel like you might pass out. So I suggest you read the chapter in my book, Diabetes Solution, about hypoglycemia. In fact, you could read the whole book. I am very confused about insulin bolusing with low carb. I have read your book, but I am not sure, how to juggle fiber versus protein in my carb count for my pump. This is why the person's having trouble. Right off the bat, if you're using a pump, you're not going to be able to get predictable blood sugars. And the guidelines that the pump makers and the diabetes educators give you, which is to ignore protein and just set your bolus dosing for carbohydrate, makes no sense. So the whole ball game in principle doesn't make any sense. But if you're using a pump for, let's say, more than 5 years, the chances are you built up scar tissue, and the insulin you're pumping in is not predictably absorbed. So you're not going to get predictable results from one meal to the next. On top of that, they advocate that you can eat whatever you want and just adjust the insulin from meal to meal based upon your carbohydrate. And of course, you never really know the exact amount of carbohydrate that you're getting. You could look it up in a table, but that's an approximation. So the whole thing is an unpredictable ball game. And there's just no way to win the game. On top of that, many diabetics have gastroparesis, which further generates unpredictable post-meal blood sugars. So I cannot give you magical answers as to how to set the dosing on your insulin pump. Then none of them are going to work. I crave carbohydrates. I eat when I am bored and tired. I am contemplating Ozempic as a solution. Ozempic is a 1 dose a week GLP-1 agonist. GLP-1 agonists increase the body's production of amylin, which is a satiety hormone. So this is a person who is an overeater and is wisely looking to a GLP-1 agonist to increase his or her satiety. The problem is that if you're 24 hours a day all week long, which is what Ozempic, that's the action of Ozempic, you're going to rapidly become tolerant of the effect. Most people who overeat at certain times of the day. Sometimes they overeat in the late afternoon. Most commonly, it's after dinner. So we can take a rapid-acting GLP-1 agonist and take it so that it's working when you're going to be craving the food. That's more likely to work. Whereas if you're giving it all day long, day after day, it's not going to work, at least in my experience. I've had a few patients who wanted to try it and had no effect on appetite whatsoever. Now, this person also says his or her A1C is 7.0, which is high, so all the more urgency to interfere with the overeating. If you read my book, Diabetes Solution, we have some suggestions for curbing overeating, and it's not an easy situation to cover. My last lipid panel revealed LDL of 172, was 94 6 months ago, HDL 98 versus 88, and triglycerides of 46 versus 35. Is this expected on a low carbohydrate diet? My cardiologist wants me on a statin to lower the LDL, which I am not thrilled to do, but would need arguments. Well, you can, total LDL has not been found to be a predictor of a heart disease or other diseases. LDL particle size has been found as a predictor. Small, dense LDL is more likely to infiltrate the walls of arteries. There are other reasonable predictors. Triglyceride is a very good predictor, and your triglyceride is low. It's even come down lower. There are other tests that can be done. I would suggest that you ask your cardiologist to update himself on the scientific literature for cardiac risk factors that can be measured in the blood. And I can list a few of them for you. There's LDL particle size, there's fibrinogen, there's C-reactive protein, and most important, especially if you're female, is LP small a, lipoprotein small a. In my experience, every patient who's come to see me for the first time, where we get a load of blood tests, everyone who's had an elevated LP small a has already had a heart attack. And that tends to be elevated in women who have low estrogen levels, and you could bring the LP small a way down by estrogen replacement. Another test that your cardiologist may want to do, which is in a sense more invasive, is an imaging test for a coronary artery calcium score. But you don't impose a drastic treatment like statins based solely upon an LDL. I read your book and did not find any information regarding diabetes type 1.5 or LADA, latent autoimmune diabetes of adulthood. I try to keep carbs between 25 and 50 grams daily, much to the chagrin of the nurse practitioner nutritionist. I can find no one who can figure it out with regards to being LADA, L-A-D-A. Well, first of all, I wonder if your nurse practitioner is obese. It's interesting that in my experience, most of the nurse practitioners I've met who advocated high carbohydrate diets and protested when people cut their carbs have been obese themselves. LADA can present with a host of different blood sugar profiles, and the name of the disease should not determine what your diet is. You should be on minimal carbohydrate, whether you're a type 1 or a type 2 or a pre-diabetic. The only reason for introducing carbohydrate is to get the vitamins that certain vegetables bring. And you don't need tons of vegetables to get adequate vitamin levels. If your nurse practitioner, nutritionist is concerned about vitamin levels, she can have your blood levels of various vitamins checked, and your diet can be adjusted accordingly, or she could give you vitamin pills. Just calling something diabetes 1.5 doesn't change the meal plan. The meal plan that I recommend is in the book, and the amount of carbohydrate actually is reduced for smaller people like children. It's in proportion to your body weight, and that's about all I can say. It would be nice if you emailed us and let us know if your nutritionist is overweight. I'm curious to hear your overall assessment on the insulin pump. I have tried to be on the Medtronic pump system twice and did not adapt. Well, I think that I've given my opinion over and over. I've never seen, I have to retract that. I have seen a couple of people who were using insulin pumps with a low carbohydrate diet, constant meals where they didn't vary their meals from day to day, and where they had were new onset type 1 diabetics who were still making insulin. By the time 1 or 2 years had passed by and they were no longer making insulin, their blood sugars went haywire. So part of the reason is, I'm sure, due to the creation of scar tissue at the needle and at the tubing insertion sites. But as I said, no long-term users have I ever seen with anything approaching normal blood sugars. I am 52 years old and have been a diabetic for 22 years. I am obese. I don't feel healthy even with normal sugar levels. Is it possible to stop using insulin by eating the right things? Well, it's interesting that this person is talking about normal sugar levels. It depends how you define normal. If you go by the ADA definition, which is under 6.7, 6.7 is an average blood sugar of about 160, about 168, which is almost exactly double normal. And so, do you really expect someone to feel well with blood sugars that are double normal? And I certainly would not expect a long-term diabetic. This must be a type 1. She's 52, diabetic for 22 years, so that means he or she was 30 years old at the time of diagnosis, therefore probably a type 1. And eating the right food is not going to enable you to stop using insulin. It just enables you to take a smaller dose of insulin, have better blood sugars, and if you're trying to lose weight, making it easier to lose weight because you require less insulin, but you can't stop it altogether. Is there a link between type 1 diabetes and osteoporosis? We should say there's a link between elevated blood sugars and osteoporosis. When I was about 20 years old, I had broken a pinky, and I went to the emergency room. They x-rayed my hands, and I guess they did both so they could compare one pinky to the other. And it was fractured, but they also mentioned, the radiologist mentioned, that the bone density in the wrists was very low. Now, I had been diabetic for 8 years, and of course I had very high blood sugars. We didn't have blood sugar self-monitoring in those days. 3/4 of 100 years ago. So I had osteopenia. You might call it osteoporosis. In any event, much more recently, I had a whole body study. I don't remember if it was a CT or an MRI or a combination with X-ray, and I asked them to look at my wrists just out of curiosity, see what has happened over the next 55 years. And lo and behold, they said the bone density was absolutely normal. So my osteopenia or osteoporosis reversed after years of normal blood sugars. So there is a link, but the link is not between diabetes and osteoporosis, but between high blood sugars and osteoporosis. My 16-year-old type 1 son is on twice daily Tresiba and bolus Act Rapid insulin. Act Rapid is regular insulin, also called crystalline. We are doing okay during the day, but after he goes to bed and injects his night dose of Tresiba, his blood sugar peaks at about 1 to 2 a.m., even to 150 to 170, and then it goes lower. Why can it be, and how can we prevent it? Well, first of all, read my book, Diabetes Solution. Might have to play around with the dinner dose of the Act Rapid. Might have to play with the timing of the dose before the meal, how long it is. He might have gastroparesis. I don't know how long he's had diabetes. If he's had diabetes for 10 years, there's a very good chance he has gastroparesis. And gastroparesis will tend to give you low blood sugars after a meal and high blood sugars an unpredictable number of hours later. So, and we have a whole chapter on gastroparesis in my book, Diabetes Solution, and there are medications for it, and there are also diets for it, and all kinds of ways of attacking the gastroparesis. That sounds like what the problem is, but I can't be sure without actually seeing his blood sugar data sheets, his meal plan, etc., etc. But you can experiment, again, with the timing between the meal shot and the meal. And, of course, the meals have to be constant from one day to the next, or you just can't get scientific data. My 22-year-old daughter is newly diagnosed with type 1. Do you have any experience with the fasting mimicking diet in retaining and or regenerating beta cells? Well, you could look this up on the internet as well as I could. This is a business where they sell food to get weight loss. It appears to be a high complex carbohydrate, low protein diet. I would not recommend it for diabetic humans. In fact, I probably wouldn't recommend it for most humans. So that's the story. Now it's a boyfriend. My boyfriend is a type 1 diabetic for 17 years. So he probably has gastroparesis. The last time we called 911 due to a hypo, I had managed to get him to drink an entire bottle of the Relion brand glucose drink, 2 fluid ounces. It's about 16 grams of carbohydrate. But after 45 minutes of administering it, he was still unable to speak or follow directions, and 911 was called. When the paramedics arrived, his blood sugar read 25. We believe he has gastroparesis. My question is, why did the glucose drink not work? Well, before we look at the gastroparesis, there are several reasons why it might not work. Let's say that he took a shot of insulin and didn't eat his meal. He delayed the meal so long that his blood sugar went down that he couldn't eat the meal. And let's say that he usually took 5 units of insulin for the meal. Well, 5 units of insulin each unit covers about 8 grams of carbohydrate. So 5 units of insulin would cover 40 grams of carbohydrate. But he had the Relion drink, which only had 16 grams. So it was less than half as much carbohydrate as he needed, because his blood sugar all this time could have been dropping from the insulin he shot for the meal that he didn't take. So that's one possibility. The other possibility is gastroparesis, where you take a shot for the meal doesn't empty, and then finally empties 6-12 hours later. I've had patients with such severe gastroparesis that it might have taken a day and a half before a meal would empty. So here, you take a shot for a meal. Let's say that you took 5 units, which would cover 40 grams of carbohydrate. If you're having protein, it would be less carbohydrate. But let's say that that meal was to include 6 ounces of protein. And 1 ounce of protein is equivalent to about 4 grams of carbohydrate. So you could redo the calculations again. If his protein did not empty over the next few hours, he could go low just from the gastroparesis. So it's not a great mystery. We just don't know for sure that he has gastroparesis, but it's very likely. An RR interval study would confirm it. The big trouble is that doctors are not routinely doing it. You could conclude it inferentially by seeing low blood sugars after meals and high blood sugars many hours later, but not on a consistent basis, because the hallmark of gastroparesis is its unpredictability. During a low blood sugar hypo, I want to sleep. Should I be encouraged to get up, sit up, stay awake? Well, when your blood sugar is low, the brain is not getting enough glucose and it wants to turn off. So you're going to want to sleep. And if you allow yourself to go to sleep instead of taking some liquid glucose, you're going to be in big trouble. So you should not allow yourself to go to sleep. You should stay awake and be checking your blood sugar and taking appropriate amounts of glucose. Again, you should read my book, Diabetes Solution. My son has studied your book, keeps a meticulous diary, and has stabilized his blood sugar levels through diet, exercise, and slow insulin. Over the past year or so, he's been eating according to the keto diet and most recently the carnivore diet. I don't know if there's a cause and effect relationship, but he's experienced 4 blackouts in the past year. All of us are very concerned that he could die if no one is around, if he blacks out again. He respects your advice, and we'd be grateful for any direction. Well, I don't like keto diets. I don't like carnivore diets. My book, Diabetes Solution, which apparently the son is reading or has read, gives the right approach. Now, it says that it appears that he's only taking long-acting insulin. Now, that alone could be a culprit, where that's the old ADA approach, where you take 1 shot of long-acting insulin a day, and you take it at a very high dose, forcing you to eat all day long. And if you don't eat all day long, you black out. So I would recommend that, as the book says, he should be taking small amounts of basal insulin, something like Tresiba twice daily, and small amounts of rapid-acting regular insulin before each meal. That can make a big difference. Also, there's the matter of having consistent meals. And again, using liquid glucose for the lows and getting a continuous glucose monitor. And as of this point in time, the only glucose monitor that will give you warnings is the Dexcom, the G6 or the G5. And that's the advice. Now, he may have that gastroparesis. If that's the case, that has to be dealt with, and that's a whole chapter in the book. My son is a 16-year-old teen type 1. After we changed to Tresiba, we couldn't get the right amount for 2 months. He always seemed to need more and more. Now he is getting 10 units at bedtime, which seems fine, and 3 units in the morning, which seems not enough. In your book, you say a non-obese adult requires a maximum of 9 units at night. I doubt that I say that. I may estimate that a non-obese, non-insulin resistant adult may need, and depends on the weight. So if this person is not obese, but is 6.5 feet tall and weighs 230 pounds, may need more insulin. Is it different with teenagers because of the growing hormones? Yes. Teenagers frequently need more insulin. In fact, I routinely, in advance of puberty, if I have a kid who's not yet a teenager, let's say he's 10 years old, I'll start him on metformin because it seems to reduce the blood sugar increase and variability that kids get when they go into their teens. And I've had kids on I have one kid who's now he's 20. I've been treating him since he was 10, and he's been on metformin all that time. It helps most of them stabilize their blood sugar. Very important. When I Google gastroparesis, it says to avoid eating meat, eggs, and dairy, just the opposite of what my son is doing based on your book. Well, you're not quite, what you read is not quite right. I encourage for people with gastroparesis, if it's mild enough for them to eat solid food as opposed to liquid meals, I encourage them to eat eggs, dairy, but I do discourage the meat. That's basically it. You've read the wrong things. Now, in the most severe gastroparesis cases, we have the patients eating only liquid meals and taking vitamin pills. And again, we talk about it in my book, Diabetes Solution. Okay, albumin-creatinine ratio results are 16.2. What does this mean? Okay, this is reported on a routine chem screen or chemical profile of the blood. They usually do 2 tests that reflect kidney function. One is the serum creatinine, which creatinine is a breakdown product of muscle tissue that appears in the serum and is cleared out of the blood by the kidneys into the urine. The blood urea nitrogen is a measure of urea in the blood that is also cleared away by the kidneys. So you're looking at 2 things that are cleared away by the kidneys. And there's a ratio of one to the other that has meaning only if you have kidney disease. If you don't have kidney disease, the ratio, if it's outside the normal range, has no meaning. For example, you can use it to determine if an abnormal ratio is due to kidney disease or to dehydration. if you're dehydrated, the BUN goes up, and the creatinine may also go up, but the BUN goes up more. It's a ratio that should not be reported unless the patient is known to already have kidney disease, or unless the patient has a high creatinine. So if the creatinine is not high, the ratio has no meaning. Normal for this test, by the way, is 0 to 30, and this person was 16.2. Even if it were 30, if his creatinine is well within the normal range, the test has no meaning. Type 1 for 42 years, since the age of 4. Well, this is another survivor. Mostly poorly controlled. I've developed a skin problem where I don't seem to shed skin properly. I must either use a pumice stone in the shower or use very hard friction. I must do this at least twice a week. This is all over my arms and body and legs. It started after about 36 years of type 1. I'm sure it's poorly controlled type 1. Is it? I have no idea. I have the closest to anything like this that I've seen. There's frequent dry skin in the feet of of most type 1 diabetics. Most diabetics, both type 1 and type 2, unless they're recent onset, because most diabetics are poorly controlled and they lose the sweat glands in the skin of their feet. They lose it there first, and then it can move up, but I've never seen it all over the body. I have, however, seen psoriasis in close to 100% of the patients that visit me. Frequently, the psoriasis appears long before the diabetes appears. I have type 2 diabetics who have had psoriasis since childhood and only became type 2 after the age of 50 or 60. So it could be that this person is describing psoriasis, but I'm not certain. I would suggest that he see a dermatologist who specializes in psoriasis. Not all dermatologists specialize in psoriasis, so it's good to find one who does. Well, thanks for listening. We'll see you again on Wednesday, March 25th. Have a good month and good luck to you.